Hey everyone, now let's learn about the myocardial infarction. It is irreversible injury to cardiac tissue. Now let's see the pathogenesis. Ulceration, rupture or hemorrhage of plaque leading to exposure of collagen, an aggregation of platelets, and thrombus or spasm of the coronary vessel leading to the infarction. Now this infarction leads to the transmural MI, transmural myocardial infarction, or subendocardial myocardial infarction. Now let's see transmural. In this, complete thickening of ventricular wall is affected in transmural myocardial infarction, and in subendocardial myocardial infarction, inner one-third of ventricular wall is affected. Now the clinical features of myocardial infarction are chest pain, which radiates to inner arm, jaw, and epigastrium. Squeezing pain is there, and the Levine sign, which means clenched fist on chest. It's clenched fist on chest. So Levine sign. And MI, where there is no pain and seen in elderly or in patients suffering from diabetes mellitus, that MI is known as silent MI. So it occurs in elderly or the patients of diabetes mellitus where there is no pain. Second feature is diaphoresis, means profuse sweating. Diaphoresis means profuse sweating. Third is increased pulse. Dyspnea means difficulty in breathing, and nausea and vomiting. So 5 features of myocardial infarction are chest pain, which radiates to inner arm, squeezing pain, Levine sign is there. Second, diaphoresis. Third, increased pulse. Fourth, dyspnea, and fifth, nausea and vomiting. Now, the blood vessel which is affected in atherosclerosis is left anterior descending coronary artery. So that supplies the apex of the heart, anterior wall of left ventricle, and anterior intraventricular septum. And we can most commonly see the anterior wall MI, anterior wall myocardial infarction. Now the diagnosis of MI, very important. Firstly, we'll do the ECG, in which we can see the hyperacute T waves, ST segment elevation, and Q wave, which is seen in old MI. Second is cardiac enzymes. So cardiac enzymes is myoglobin, first enzyme to increase in MI, normal within 24 hours, and it's not specific. Second enzyme is creatine kinase. It is CKMM, CKMB, and CKBB. CKMB, which is most useful for MI diagnosis and also increases in myocarditis. So most useful for MI diagnosis is CKMB. Now the troponin, third cardiac enzyme, which increases in 24 to 48 hours, elevated for 7 to 10 days, and it's of two types, cardiac troponin T, cardiac troponin I. So I is more important. We can remember it by MI and this. That's why MI, you can remember like that. C, cardiac troponin I, which is more important. Best enzyme for diagnosis of MI is most specific and sensitive, and also useful in diagnosis of reinfarction. Now the LDH. In normal person, LDH2 is more than LDH1, but in a person suffering from MI, LDH1 is more than the LDH2. This is called flipping of LDH ratio. LDH is the last enzyme to increase in MI. Now, the TTC stain, which is triphenyl tetrazolium chloride plus LDH. So normally the intracardiac LDH is brick red color, but the MI in which we are having leaked out LDH, it is pale or yellow color. So third one is echocardiography, third diagnostic test of the MI, echocardiography. In this, the hypokinesia occur, which means decreased heart valve motion, and akinesia means absent motion. Fourth is thallium scan, in which we can see here we are having diffuse staining, and in the infected area here, this is infected area, which is picked up against the normal background or viable area. Now, fifth one is biopsy. So it's also very important, biopsy of MI. Now less than 4 hours, we can see there is no change. So 4 to 24 hours intercellular edema means waviness of fibers, and pale on TTC staining means triphenyl tetrazolium chloride, and pale staining is when the amyl there is leaked out LDH. So now the 24 to 72 hours coagulative necrosis, neutrophilic infiltration, and infarct with yellow border. So here from 24 to 72 hours coagulative necrosis, neutrophilic infiltration, and infarct with yellow border. Now 3 to 7 days macrophages are present, neutrophils decrease, hyperemic borders. So from 3 to 7 days macrophages are present, neutrophils decrease, and hyperemic borders. Now from 7 to 10 days the granulation tissue, red brown margin, scar is present but very less, but from 4 to 6 weeks scar present, and which is white scar. Here you can see the structure of heart, and we can see the zone of perfusion, the area which is at risk, and here the acute coronary artery occlusion has been occurred, and this is pulmonary artery, aorta, and the right coronary artery is here. Now in this diagram we can see the complete infarct involving the entire area at risk. So when we see the cross section of the myocardium, we can see at 0 hour the zone of perfusion, this is zone of perfusion, and this is endocardium, and this is obstructive coronary artery, and after 2 hours we can see the zone of necrosis, and this is the obstructive coronary artery, and after 2 hours in 24 hours we can see a zone of necrosis area has been enlarged, and or we can say that the zone of necrosis has been expanded to involve the entire wall thickness. It expanded. So here the zone of necrosis has expanded. Now let's learn about the reperfusion injury. It is due to sudden influx of WBCs, free radicals, and calciums. Factors that contribute to reperfusion injury are mitochondrial dysfunction, myocyte hypercontracture, free radicals, leukocyte aggregation, platelet and complement activation. Now the morphology of reperfusion injury is irreversibly damaged myocytes after reperfusion develop contraction band necrosis. So contraction band necrosis is seen in reperfusion injury, which is due to the calcium. Now let's learn about the complications of MI. So first complication is arrhythmias, means so the first complication is arrhythmia, which can be the decreased heart rate, which is bradyarrhythmia, and the ventricular fibrillation, which mostly occur within 1 hour treatment by defibrillation, and most common cause of death in first hour of MI. Now that was about the arrhythmia. Second is cardiac failure. Here the third one is cardiac rupture syndrome, which is seen after 3 to 7 days after MI. So affects free wall rupture, which is most common, intraventricular septum, and mitral regurgitation. So it's cardiac rupture syndrome, which affects free wall rupture, intraventricular septum, mitral regurgitation. And fourth complication of MI is the autoimmune pericarditis. Fifth is ventricular aneurysm. Aneurysm means dilatation. And sixth is contractile dysfunction, where there is severe pump failure because of the cardiogenic shock. And seventh one is papillary muscle dysfunction.